Alright, so when placing a chest tube, the anatomy things that we look for. Obviously, we're placing the chest tube into the patient's chest cavity to relieve some sort of abnormality, be it air from a pneumothorax, tension or simple, or maybe fluid or blood has built up from various processes. However, we also need to remember that there are several very important vital structures within the chest that we need to make sure we avoid, and also remember that there is an overlap between the abdominal and chest cavity, and certainly don't want to place a chest tube into the abdominal cavity or into any of the abdominal organs. That means that we have a very specific area in which we're able to place a chest tube that will keep all these structures safe and then still treat our patient's abnormality. We like to place a chest tube somewhere between the 4th and 5th intercostal space, which on a male patient generally coincides with in line with their nipple. However, obviously in female patients you can't use this anatomic landmark because it won't be in the same place. And we also try to do it somewhat lateral so that we're usually about in the anterior axillary line. Okay? The other things we make sure we avoid are the fact that we have arteries, veins, and nerves that underlie each rib. And so when placing a chest tube, we make sure that we go over the rib as opposed to underneath it. In order to maintain a good seal in our chest tube, we generally make an incision along the top of our rib. This also gives us some support for the knife, and then use our clamp to tunnel over the rib and into the chest cavity. This is done under sterile technique with the patient anesthetized on the skin using lidocaine, and then hopefully we've used a systemic relaxant and medication as well if the patient is awake and alert and talking to us. So we would go ahead and sterilize the skin with a prep, anesthetize it using lidocaine, and then go ahead and make our incision. An important thing in finding our landmarks for incision is to be able to fill the ribs, which on some patients can be more difficult than others. In this particular patient, I can fill a rib just there, so I'm going to make my incision literally on top of that rib so that I can tunnel over it. Using my 11 blade, making sure I'm in the anterior axillary line, I go ahead and make an incision down to the bone. I can feel the bone. Now you need to make an incision that's big enough for your tube to get in. It's more important that you make an incision big enough and easy enough to work in than it is to make it small enough that it goes around your tube. We use 2 Kelly clamps, one to clamp the tube. Once you get the tube in, it will start draining immediately, and so you don't want to have it draining all over you and everything else while you're getting it connected. The other clamp we initially use to help us do that tunnel technique. So we go through our incision, feel our rib, and feel to go over our rib. Now notice how I'm holding the Kelly clamp. I use my index finger to help control the depth I'm going to insert my Kelly clamp into the patient so that I'm not jabbing all the way. If I hold it all the way back here, I could conceivably insert this Kelly clamp all the way that distance and hit some very important structures that the patient and I really don't want to hit. So in, feel the rib, go up and over, and it does take some force to push through the chest wall. There's a lot of musculature there, and they're very strong muscles obviously because they help us breathe. Now once you feel yourself pop through, oftentimes you'll get a rush of air or fluid depending upon what your patient's particular disease process is. When you get through, you want to go ahead and spread your clamps as wide as they possibly will go, and this does take some force because there's quite a bit of resistance. And then you want to try to pull them back as open as possible to maintain that. If you haven't made a good track, you can lose your track very careful if you're not very careful. The other thing you want to do is go ahead and get usually a pinky finger in to make sure that there's not lung adhesions to the chest wall or something like that that might be in your way. Once you've done all that, you need to go ahead and clamp your chest tube up here at the top with your remaining clamp so that you flatten it out so that it actually will insert into the patient. Remember, you have ribs that run parallel like this. You need to flatten this out to get it between the ribs and then open it up. There are various ways to do this. Some people go in through that last hole. Other people just clamp it like this. The most important thing is that you can get it in and not pull it right back out when you try to take your clamp out. Other things you notice, the last hole on this tube is right here, and shortly thereafter my numbers start. So I need to know how deep I want to put this in my patient. But oftentimes we'll look and just kind of gauge based upon the size of our patient where that lands. On this particular patient, it would land about 14 if I was aiming for the apex. Most important part is that that last hole is within the chest cavity rather than outside the chest cavity, because that tube will not function properly if it is. So go ahead and clamp. Find my track again. And once I get my tube in, pull my clamp out. And insert my chest tube in. As you can see, I'm having a little bit of difficulty with this, and that's because my track actually collapsed somewhat as I was talking and demonstrating. If I have any problem with that, I can go back in with my clamp and just dissect those tissues once again and try again. Now that I'm in, the other thing I want to make sure that I do is I want to angle this tube so that it will go posterior to the lungs and apical. So the way we do that is to twist it so that we're pushing it down and up as well, and it will lie in the proper position. Okay, now at this point in time I've pushed it to about the 10 mark, and as I measured earlier it was about 14. But I'm going to give myself a little extra room because I really don't want it hitting the patient up here. It's very uncomfortable for the patient and oftentimes won't work very well. Once you've done this, you would certainly then connect your chest tube to your Pleurovac or your chest tube apparatus and secure your chest tube with a suture and a gauze dressing, as well as ordering a chest x-ray to ensure proper placement and adjust it from there.